Hey, good morning, y'all. Today we're going to do grand rounds for the Mentoring and Functional Medicine group. Today we have a really interesting case. So let's see, we should be on case number 6, which is 37-year-old female with migraines. Now, this is a handful of patients over the last 20 years and clients. This one, 12 years of migraines. Typically, we're going to see people coming in migraines that have just had it for a long time and they've just been medicated, and eventually the medication doesn't work. They still have breakthrough migraines and they're kind of like at a loss here. So in the beginning, when the migraines come, it's like the greatest thing ever for getting diagnosed with something. Sometimes they're very peculiar. People can't quite figure out what's going on with that. They have these crazy auras with them, scintillating scotomas, just flickering lights going across and all kinds of stuff. So, finding out that you're not broken, you're normal is important, but getting that diagnosis, the treatment typically, again, is just medication for life. And so with this is a 37-year-old female. She came to us with a 12-year history of migraines, currently experiencing about 8 to 10 migraines per month, which is, again, quite a bit. A lot of times we probably see more like maybe once a month with their menstrual cycle. Yesterday we had a client come in she's doing 2. So she said it's with her cycle, but it's actually 2 times a month. And she's been having those for over 10 years. So quality of life, of course, this is just life ending kind of thing. When they get these pounding headaches or visual disturbances, audio disturbances, like you can't function, you can't work. Most of the time, the typical scenario is they're going to go into a quiet environment. And so they're going to go in the bedroom, lay down, lights off, that kind of stuff. So less stimulation for them. So that makes it very difficult for relationships, going out, having fun. And it's always interesting to see what triggers those things, because we don't always have a good understanding of why. Sometimes it's vasoconstriction, sometimes it's vasodilation, sometimes it's chemical, sometimes it's stress. So I know I actually had, I think, a migraine for the first time in my life. But my office faces the windows. My desk faces the windows. So I'm staring at the client. Behind the client is a huge, giant bay window. And I keep my lights off because I don't like the fluorescence. They give me headaches. But so, it's this kind of like calm environment in my office. But that light sometimes just gets overwhelmingly bright and I'm trying to focus on them. And then there's all this other bright light. And man, maybe 2-3 weeks ago, like my brain just, like I felt weird, like there was like a halo. And I was just like, well, this doesn't seem right. Like, am I having a stroke? And like, I think it's just some weird visual thing. And so I was just like, fine, I'll keep seeing clients all day and pretend like nothing's wrong, although everything is glowing and halo. So I was seeing the last client of the day, and I say a lot of the same stuff, same stories, same anecdotal stuff to people to try to get the points across. And I just this constant I guess aura, like I couldn't quite keep track of my thoughts, and I was pausing, and I was like, I knew what I was supposed to say, but I couldn't quite come up with the words exactly. And then you're like self-aware of that. And then you're like, am I having a stroke? And I was like, well, it's got to be the visual thing, it's got to be that. So I think I had a migraine. And since then, we got blinds and we had these little decorative things put on the window. So it's not so just shockingly bright all day staring in my eyes. And I haven't had anything since, but oh my gosh, like if that's what they feel like, I totally get why it's just life upending. So if you've had one, if you haven't, like before all that, I was just like, well, that sucks for you, but let's get it fixed, right? So quality of life, Basically work, exercise, family, social, frequency of canceling plans because of unpredictable attacks. She was losing approximately 1 productive day for every severe episodes. And so about 2 a week, or a little bit more. So she's losing about 2 to even 3 days a week of productivity, of quality life. Now, medication, typically it's pretty standard. They're basically kind of trying to shut down the neural pathways. So naproxen sometimes for pain, but it's a COX-1, COX-2. So you got liver issues, you got kidney issues, you got cardiovascular issues with that for long-term use. So you really shouldn't use a COX-1, COX-2 for very long, right? I mean, the COX-2s have a black box warning from the FDA that increases your cardiovascular risk by 35 to 38% for chronic use. So you really don't want to use too much of that. And then the topiramate, 25 milligrams at night, and then titrating according to kind of response, how tolerable it is. Propranolol, that was 40 milligrams. And then sumatriptan, she came in with that, 50 milligrams by mouth for migraine onset. So typically when these clients come into your kind of functional medicine, lifestyle medicine, clinical nutrition kind of practice, just know the conventional treatment is always to separate the acute from preventative therapy. So you're going to have some PRN kind of treatments that when they have something, this is what they take to shut it down and get over it faster so they can get back to their productivity. But we also have preventative, which is just kind of like subduing, like we do with seizures. But with seizures, again, it's just you're kind of shutting down things to where then quality of life's not good. And how long can you survive that, right? So you're trading a lot of times one quality of life for another quality of life issue. And preventive therapy is considered in patients with frequent headaches, at least 4 days, or substantial migraines related to disability and ability to do activities of daily living. The American Headache Society, just for a note, they consider that 4 or more headaches per month chronic. So typical, basically NSAIDs, and that's kind of COX-1, COX-2, PLA2s, anything besides steroids, right? So NSAIDs are non-steroidal, so that's the prednisone and the corticosteroids. And triptans, gepants, I'm probably not saying that right, and then other agents are preventive therapy. And then that topiramate, that's, and certain beta blockers and CGRP targeting treatments are basically the chronic management here. So they don't have to worry about surgery with this. They typically ain't cutting people up for this. So when in doubt, cut it out. They ain't cutting the brain out here. So this has to be a common thing, again, where you have the typical practice where they're spending, 18 minutes or 18 seconds before the doctor typically interrupts the client or patient. 2 minutes, they have a tentative diagnosis. 5 minutes, they have a prescription out the door. So we have about a 52% failure rate within diagnosis and treatment, because nobody's going to do a whole lot for this until they go to a specialist, and then they do a whole lot of tests, and then it's the same treatment. So you'll get these clients all the time. It's pretty common. And then, so she comes in, years of this. We do our basic functional lifestyle medicine protocol, right? So we do the comprehensive intake, look at everything that's going on with this patient, and we want to know not just migraines, but what's that total clinical picture. Once we have that down, which is almost always 30 to 60 to 90 things, then we go through our functional lifestyle medicine protocol, at least at our clinic. So we first start making giant food changes, then we make chemical changes. The food stuff, especially the food sensitivity testing, is critical for migraines. This is where we see people just flip overnight. Now then we got to fix why they have it, which is the rest of the protocol, which is change the foods, change the chemicals, and change the stress. So whatever's triggering it, usually once you get those histamines down, and we don't care whether it's histamine 1 through 9, we don't care about the T helper cell 1 versus 2 or T17 or regulatory, because what we do is just concentrate on creating normal and letting the body fix itself, which is super successful and a lot easier than trying to manage this stuff. A lot of times you're going to see functional medicine, clinical nutritionists, basically like, well, what's the medical model? Let's just do the natural versions of that. And that's kind of how I started out, because that's how you're taught. And so, oh, don't take ibuprofen, it's going to kill your kidneys, take willow bark. Well, why do you have headaches? Like, why don't we just fix it to where you don't need willow bark? Instead of treating stuff forever naturally, how about we just teach how to fix problems, right? And as long as we have good clinical outcomes, right, we have a 95% success rate that we try to keep, then it's all fine. So you don't need to manage. So once we get through that, going over the food sensitivity test, understanding that when I eat these foods, those are what's triggering this sudden histamine spike to that symptomatic or critical threshold that then has the onset of the migraines. So you'll notice once you get rid of that, they go away. I think migraines may be pretty easy, pretty quick recovery. On this case, it was 3 months before she was migraine free. It takes 6 weeks, maybe 2 months to get through the protocol and for them to really make substantial changes to see the benefit, and almost always a complete resolution by that time. So then we just want to make sure that she keeps sticking to her lifestyle changes, the food, the chemical, and the de-stressing. And migraine, so 9 months. So she went from 9 a month to 2 a month to 0 a month. And then she, during that time, was working and getting off her medications. So then we have a true assessment of really what's going on with this client. And then on follow-up, the patient reports being able to exercise now, improve work attendance, and of course, few to no canceled activities. I do tell, especially my female patients, that if they had something, everybody's used to them like checking out, that sometimes maybe take a migraine day, just say, oh my God, I'm having a flare. I need to go lay down and watch TV. Nobody bother me. And since everybody's trained not to bother them, why not use it to your advantage? Sometimes we just need a little time. So that's our case today. We probably have a few more within the next 70 case studies on migraines, but they're pretty easy. I mean, pretty straightforward, just like everything else. All right. I appreciate you guys. I will see you next or tomorrow for Grand Rounds.